There are certain things that are just patient retention killers. What are some major patient retention killers? Number one is adjusting on the first visit. That's a killer. And the reason it is it tells the patient this is going to be quick and fast. It's not going to take long. It's going to be quick and fast. And there's no value built up or very little built up prior to day one and an adjustment. It's a patient retention killer. Now, you want to treat the patient, therapy, but you do not want to adjust them. And then that's a killer. Another one is collecting money on every visit. You're reminding them of the obstacle. You're magnifying the obstacle. Remember, the formula is need equals money times time divided by trust. So when you collect money on every visit, in other words, you don't do prepays, you're magnifying the obstacle as the need is going down. It's like the worst thing you could do. It's the worst dynamic possible. You know, the best dynamic, obviously, is when there's maximum need and the obstacles of time or money are significantly reduced. That's the absolute best scenario. I mean, that's what you're shooting for all the time. That's what you're trying to establish. And in an affected, trusted environment. So when you don't do prepays, the perceived need starts going down more and more, especially if you didn't do or did a bad job with patient education, especially. So that goes down fast like a rock. And then you're magnifying the money on every visit. So on the third, fourth, fifth visit, you're collecting money. You're just pushing them out the door is all you're doing. That's what you're really doing. So that's a major one. Another one is not to have third party trust as the focus for the care. Remember, it cannot be based on you. Why? You're a chiropractor. You got 67% negative name recognition. You know, when a neurosurgeon talks to a patient, that's a whole different response that patient gives a neurosurgeon versus a chiropractor. By the way, the number one trusted health profession is the pharmacist. So it can't be based on you for that reason, number one. And you can't leave it on them because they only know symptoms. That's all they know. That's all we know. That's all. Before I know anything, that's all I would know. Matter of fact, if I went into, to the medical field for something, a disease I didn't know, as a chiropractor, I wouldn't know what to base it on besides my symptoms. I wouldn't know. That's why that patient education is so important. So it has to be, that's the single most important concept of patient education. It's got to be based on, you got to get an agreement that it's based on.
Hey, big boy. Hey, what's going on?
It's based on the patient's, on the patient's third-party biomarkers trusted. Now, obviously, it's better if it's biomarkers they already trust. That's why the blood test, when we do the lifestyle patient retention, the number one biomarker is the blood test, the high inflammatory for inflammation. So we're looking at the high inflammatory blood test. Blood tests are just trusted, just unbelievable when you look at the spectrum of tests. So the X-rays are too, but the problem with X-rays is people who don't read X-rays. So you got to be really good and simple to explain this, in a really simple concept, what's happening with these X-rays. I don't know if you guys remember the first time you looked at an X-ray in, your freshman class, especially when they showed the obliques and, in the Scotty dog. And they're going, oh, and the Scotty, and you're going, where? Where's the Scotty dog? Well, you got to remember, the patients only see grays. then we see shades of grays. And too many chiropractors think and talk to patients like they actually know really well x-rays. And a patient's not going to say, hey, I can't see what the hell you're talking about. They're not going to act dumb. So x-rays are good for third-party trust, but man, you got to really dumb them up. That's why you don't want to, that's why you only want to show the one angle that shows the problem the most, because it gets confusing fast. And that's why when you do show the x-rays, you drill the hell out of them. A normal x-ray, whatever you're going to show them that's abnormal on theirs, you should have those x-rays in normal. And you drill them because you're trying to imprint them into normal. This is normal. So when that x-ray comes up, when you show them theirs, it's much easier to see. That's like when doctors start with me, most doctors, when they start with me, they've never looked at intersegmental dysfunction with x-rays or orthopedic tests. Most doctors, when they come to me, never have done motion studies. They've never done overpressure, and they've never evaluated fixations. Those are the intersegmental joint tests. And so a lot of times when doctors, start trying to pay attention to intersegmental motion, it's hard for them. It's because they're used to seeing the big picture. They're not used to going into an individual motor unit. And so it takes a little bit to get your eyes to focus on a motor unit and the movement of the motor unit, of normal versus abnormal, and the degree of abnormal. And that's why it's real important to use lines. I mean, I literally, write it while I'm showing the x-ray. I just literally had, whether it was a ruler or whether it was I just literally just went zip, because patients can see converging and diverging lines way better than they can see two gray looking things. See, remember, they just see things in gray, shades of gray. That's way overlooked. So anyway, and then multiple contacts. The power of the natural purchase cycle. I say this all the time. You would increase your patient retention alone if you're a chiropractor doing a 2-day report of findings. That's typically what chiropractors do: exam, consultation, therapy, and then report of findings on day 2. You would, if you just took whatever it is you're doing in those 2 days, if you just took them and spread it out over 4 days, and the 4th day you did the report of findings, you would naturally increase your patient retention. You'd get way more people accepting care, just because of 2 main factors. One is the natural purchase cycle of a human being. You do not want to violate that. Remember, the natural purchase cycle: need analysis, presentation, obstacles, close. Every time we buy it, that's what we go through. Whether we buy a candy, a little, a Snickers bar at the counter, we're still going through those 4 stages. They're just happening real fast, but that we're still going through them. Doesn't matter what we buy, that's what we go through. So when you violate that, and so you don't want to violate the natural purchase cycle. That's the 4 steps. But then the benefits, the byproducts of multiple contacts with trust and confidence and defenses and resistance. Because the vast majority of the trust and confidence shoots up between the 2nd and 3rd visit. There's a natural byproduct when you meet somebody and you talk to them, you move away and you meet them again, talk to them. Your trust and confidence goes up and your defenses and resistance goes down. That's a natural byproduct, unless you are saying or doing something or weird or stupid. But that's the natural byproduct. And so that's also why you want to use it, because it's between the, so after from day 1 to day 2, there's a different level of trust and confidence and defenses and resistance, same as there is from day 2 to day 3 and day 3 to day 4. So again, you would naturally have more people accept your care if you just went through your report of findings on day 4 as a natural byproduct of multiple contacts of trust and confidence and defenses and resistance. It would be just natural. And these are the things that doctors violate when they don't do our system. Those are the things they typically don't do. They cut out the 4-day report. They violate the patient's purchase cycle. They decrease the effectiveness of the multiple contacts relative to trust and confidence and defenses and resistance. And a lot of times doctors don't talk money, or if they do initially, they start getting what's the word? Sometimes tired, sometimes it's confrontation. So a lot of doctors that got really bad money issues, really bad money issues. And I hate to say it, but I've never seen a successful doctor, highly successful doctor financially, that cannot overcome his money issues. You're never going to have somebody else collect money as well as you can, unless it's your wife. Wives don't have to know how to go after the money. But anyway, that's definitely, those are the big issues that constantly are being violated when doctors, attempt to do the patient education we teach, but they don't get the results as the guys that just implement it, from start to finish, from scratch. They just do it because it's all based on natural conscious and subconscious purchase patterns. That's what it's all based on. That's why it works so well when you actually do it. But then when you pick and choose, it goes to hell. So anyway, those are some major issues. Now, when you go to money, Scott, day 1, you're collecting on you do collect on day 1, right? At the end of day 1, you collect for day 1, right?
Right.
Okay. That's normal. And then you've lined them up for day 2. We do present time consciousness, right? You're familiar with that word, right? That concept.
Yeah.
Present time consciousness, you cannot violate. That's another major issue it's violating. You have to stay within the categories of where that patient is in the purchase cycle. You cannot violate that. That's why, there's definitely things you have to say on day 1 in a certain order that they want consciously and subconsciously. And the same with day 2, and same with day 3. You cannot violate that. These are all reasons why your patient education won't go well. You won't keep patients. They won't prepay, all that kind of stuff. So day 1, we're only lining them up for the next day. So they come out day 1, they pay. And then we schedule them for the next day. That's it. We don't talk about anything else. And then that's when you're going to cover the cost per visit and ask for 3 days. Are you doing that, Scott?
Yeah.
Okay.
I mean, a lot of the ones that are still paying by the visit are like the older patients that we've had.
You lost me.
I was just saying, like a lot of the patients that are still paying by the visit are like the older ones that we've had.
Do you understand you need to convert those?
Yeah.
You cannot let that go on. You've got to get it in your head. You've got to go through the multiple resistances to not let that happen. It's a killer. And so the way you do it, let me just walk through and I'll just go through how that's done. So on day 2, obviously, we're going to have them pay for the next 3 days, and we'll give them a 20% discount for doing that. That's how we'll do day 2, end of day 2. Now they're good for day 3 and day 4. And then of course, day 4, we we go over the treatment plan for all 3 phases of healing, tally up the costs for the care they want, and then spread it out over certain many months, and then divide that into biweekly payments. Why biweekly payments? We want to get it down to the lowest perceptible amount, because remember, it's a ratio. What's the perceived need relative to money and time? That's what you're dealing with. So that's why we want that biweekly payment down as low as possible. And when we go into in depth, are you still doing report of findings on day 2 or day 4?
I'm doing mostly on day 4.
Yeah. You know what that tells me? Chad, you know what that answer tells me?
He's picking and choosing what he wants to do and what he don't want.
And what was the key phrase of how you knew that? What was the key word of how you knew that?
It was more the tone versus
The word. No, the word was mostly.
Yeah, mostly.
That's what gave it away. When you're actually doing it, you'll never say mostly. You'll go, yeah, that's what I do. That's my system. You'll never hear me say, well, mostly. If that's a system, I'm like, hey, Dr. Paul, when you get on your motorcycle, do you turn the first thing you do you turn the accessory on? I'm like, yeah. There's no mostly in there. That's the system. That's what you do. That's step 1. I'm like, yeah, that's the way you go. It's absolute. It's not, well, mostly. See, that's just clues that you're not being rigid with your systems, and you're just, like Chad said, you're just picking and choosing, and you're just being weak. You're being weak with your system. That's what you're doing. But that's up to you. You do what the hell you want to do. And then, of course, you get those results. So anyway, you go to day 4, and then you divide that money out. And the first thing that you do is whatever money it is. Okay. So that's what you should remember. There's tiers of how you're going to go after the money. What's the first tier? You've already kind of decided, you already kind of know in your head, what the copays are going to be relative to the visits. So you should already know about really 6 scenarios of money relative to their copay and relative to the number of visits, whether they're younger or older. You should already know that. You should already have figured out those 6 scenarios and how it's going to plot. That money's going to plot out over so many months, and then turn it into biweekly payments to get down to this amount of money. That's what you should have already done. Okay. It should not be accidentally happening in front of the patient. Okay. That's the first level. Now, when you do it right and you're pretty decent at it, you'll get 50% of the people say yeah to that. If you just stick to the system, you'll get 50% of them to say yes to that. That's not difficult at all. And then your skill level will take it up to 70, 75%. There's usually always 10 to 20% that won't do that, roughly. Okay, so let's say there's only 50%. What's the next thing you do? You give option 2 and you extend it out. You extend it out significantly. There's really 3 options how this works. The second option is like the no-brainer option. It makes it where it's like this is a no-brainer. This is like the lowest thing that you'll do. That's the second option. That's the no-brainer. That's what that is. And I'm not talking about going from, $97 biweekly to $95 biweekly. I'm not talking about ridiculous stuff like that. I'm talking about significant drops. This is like your no-brainer. That this is what makes it affordable for 98% of the population to come through here, period. that money's not going to be the issue at all for 98% of the people because of this plan right here. Might be $47 every 2 weeks, whatever. Okay. So you have to have that plan. Because remember, in the preemptive strike, you have to address the obstacles. You have to. And so in that preemptive strike, when we talk about time and money, if you remember, we say, hey, Mary, we know, your health considerations are, the two factors that are important are the amount of money it costs and the time you spend. And so we have two office policies. That's when we go into office policies of time and money. Okay. So, and then the third option is turn it to them. What would work for you? And then what you always want to do as the worst case scenario is if they go, no, 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 what's the last worst case scenario that you want to shoot for before you go to daily payment? When they come in and out, they pay. Because that's a nightmare. You want to do everything you can to not do that. The next scenario is ask for the payment for the to the next re-exam or the first re-exam, depending on where the patient's at. Are they existing patient? Are they an old patient? Are they a periodic patient? It doesn't matter. Then you're going to ask for the money for up until the first re-exam. And then what's the purpose of that first re-exam? Or the next re-exam if it's a regular patient. This is how you would do it if it's a regular patient. Is the next re-exam is to redo the test. And you should just memorize this phrase. To redo the test to determine if you're getting better, worse, staying the same, or if you're going to end up with a permanent problem to some degree. You should just memorize that phrase. The tests determine if you're getting better, worse, staying the same, better, worse, staying the same, or ending up with or if you'll end up with a permanent problem to some degree. And by the way, that's what the tests are for. So that's the reason, that's the why. See, that makes sense to somebody. So that's what you want to go for, Scott. You don't want these people just coming in. You want to educate them, get them up to speed with the 3 phases of healing and what their care is based on. And then with those patients, and I'm referring now to like older patients that have been used to paying per visit, then that's when you deliver to them, you go, this is what your care is based on. These are the tests. And if you want the cost for and I would do this for your existing patients. So the cost for each visit is this amount. To the next re-exam is 12 visits. Multiply 12 visits times your cost per treatment. Subtract out 20%. And then you even can divide that into 2 payments if you wanted to make it 1 payment or 2, because 2 payments would be 1 payment today and then 1 in 2 weeks, because 12 treatments is at least going to be a month if you're seeing them 3 times a week. So after you even deducted 20%, you could break that into 2 payments. That's way better than what the hell you're doing. You want to do everything you can. Look how many levels of resistance I went to. I went for it all first, a great plan second. Then I went to the third one was the re-exam, to get to the re-exam. The very last thing that you accept, and it's the fourth resistance, not the first. It's not the second resistance. It's the fourth. What would work for you? And if you did all that right, I mean, what percentage of my patients actually paid per visit? Man, it had to be definitely less than 3%. Definitely. Because that just was not allowed. We knew it was a patient killer. It's a patient killer when you make them pay every visit. So take those concepts into consideration with what you're doing and go, how many are you violating? Well, you're going to get the results of it.